Testing 1, 2, 3, testing.
Georgia State Nurses Association a recommendation that we request AMA some help in setting up levels of nursing. The board approved this recommendation, and we went to the, or it was sent to the GSNA Board of Directors. The GSNA Board of Directors approved a motion or passed a motion that AMA be requested to send a special representative to lend assistance with the problem of the professional registry. The letter then went from the GSNA to AMA asking for this representative to come and explaining part of the problem or part of the issue that we will be talking about tonight. And today we have an answer to that request to start with you. The answer is in the presence of Mr. James Hudson. Mr. Hudson is a registered nurse. He is a graduate of McLean Hospital in Waverly, Massachusetts. He's also a graduate in the master's program from New York University. His experience has been in the area of being an instructor in the Diploma School of Nursing, a director in nursing service at a generalized hospital. He's been in organizational work since 1958, serving in the past as coordinator
Many problems seem to be growing in numbers and momentum. Competent nurses are leaving acute hospitals. We might ask ourselves, are we really looking after the welfare of the patient as is stated in the purpose of our organization if we permit the continued deterioration of the proper distribution of nurses where they are needed? The dangers of a decentralized placement service beyond the control of the ethical standards of the professional nursing organization are well known to us all. Private duty nurses in many states are taking definite steps to improve their clinical competencies through evaluation programs, institutes, and workshops. In certain states, continuing education is required for members of the registry. In California, clinical private duty nurses are allowed to charge more than the statewide fee. Emphasis in this effort came after the 1958 AMA Convention. From an article entitled The Law and the Nurse, AJMA 1964, the private duty nurse is responsible for her own negligent acts. Rarely has she a legal right to practice in a given hospital. The nursing director is responsible for all nursing dignity and take her place in the health field tomorrow.
As you recall, a letter was directed to all the directors of nursing service requesting their assistance with suggestions about the registry and how it could be improved. For over a year now, there has been a conference group of the nursing service directors of the Metropolitan Atlanta who meets quarterly. And I asked them at the January meeting if they would consider taking up this request that you had directed to them, since this same group, with one representative from your organization and a representative from the Medical Association, actually comprise the advisory committee to the private duty registry. This was discussed at the January meeting, and it was decided that a subcommittee would be appointed to study the material that had been sent, and then to draw up some proposed recommendations for approval by the nursing service group. Excuse me. Is that better now? I'm not used to these things. So then, when we completed I should tell you that the subcommittee appointed was Ms. Helen Graves as chairman, Ms. Ruth Henry, Mrs. Howard from Georgia Baptist, who was not able to attend the meeting, and Ms. Ruth Henry from Piedmont and Mount meeting. We met at Emory and had quite a long discussion and gave Ms. Graves some suggestions to compose a statement. The statement that you have in your hands tonight was compiled, the final statement was compiled by Ms. Graves at Emory. Now, I think the easiest and best way to do it, if I may, just so Mrs. Armstrong, is simply to read it. And then, because I think it's self-explanatory, and then I'll try to answer any questions that you have as the meeting goes on from our point of view. When we met in a call session at St. Joseph's, I guess about a month ago, and I thought this was most significant. These proposals were accepted as presented by the majority of the nursing service directors in the city. And I thought that the significant thing was that we would do this in concert, which has been a little unusual in Atlanta. But I want to assure you that the nursing service directors are interested in doing what we can to be of help to you. So that in mind, we'll just read it. Serious thought has been given to an overall purpose for registered individuals who will be engaged in private practice nursing in the metropolitan area. Because of changes in society for healthcare, traditional patterns of private practice nursing of necessity must also change. More and more health institutions have developed clinical facilities and clinical staff for the care of patients with complex nursing care problems. It is doubtful that private duty nursing practice, by the very nature that it is independent practice, could be expected to provide the highly specialized care to care facilities, nursing homes, patient homes, as well as in acute hospitals. And one of the remarks made at this last meeting that we had was that the director of nursing service can no longer sit in her hospital and say that my responsibility begins and ends here. It goes beyond the confines of the institution. And as time goes on, it will be extended more and more. The changes in health, as well as in healthcare facilities throughout the metropolitan community, demand that nursing take the leadership in establishing ways to meet the nursing needs of people for private practice nursing and offer some safeguards for the community patient consumer of the service. The following suggestions are offered. That the name of the registry would be a registry for private practice in nursing, and that all groups of personnel who do private practice nursing could be in the central pools, which should serve the community as a whole, and include professional nurses, practical nurses, and patient sitters. Its purpose would be to cooperate with nursing and health agencies in meeting community needs and to maintain the high standards and ethics of nursing. The registrants, of course, would be professional nurses, practical nurses, and patient sitters, as we now see it. Maybe there will be others later. Each registrant would be properly screened through admission requirements of educational preparation, experience, background in nursing practice, references from previous employment, determination of levels of abilities, and licensure and membership in professional organizations where applicable. It is believed that professional nurses should set the standards for all those who engage in nursing practice and establish the requirements for registrants. The sponsorship we felt consideration should be given for a registry within a community health agency with control for policy of operation by the profession through its organization. If a registry for private practice of nursing is to serve a community need for services, the community could be involved. Our thinking was about this, that actually it's not just you and I who are concerned with meeting the health needs or nursing needs of this community. It's the whole community. And so the community should share in this. The administration of the registry, we suggest that a well-qualified director with clerical assistance should be provided. The administration of the registry should be by a professional nurse director with qualifications in nursing practice, nursing service administration, personnel management, evaluation and counseling, and in development of educational programs for the registrant. One who is oriented not only to quality of nursing practice, but sensitive to community health needs is felt needed to give leadership and direction to such a registry. Included in her responsibilities, I say her, it could be his, I guess, would be reviewing of applicants according to qualifications set for registrants, developing in-service educational programs for the various groups, interviewing and orienting new registrants to the responsibilities they would be undertaking, and keeping up with evaluation of performance and effectiveness of the registrants. Each registrant should have a individuals who are in need of services from a private practice of nursing registry would be expected to give good exchange of information about what nursing needs are being requested in order that proper placements could be made from the registry. Educational programs should be developed on a continuing basis for members of the registry to help them develop a personnel to their fullest capacity in order to be able to practice and meet the service needs requirements of the community. For example, where professional nurses may feel inadequate to care for patients because of more or continuing knowledge, programs would be planned through the director of registry and records kept of applicants in service educational endeavors over the years. The establishment of the registry of the private practice of nursing through a sound community health agency, I think she must have meant to say through some community health agency, should be made known to the public at large in order that the community citizens would know what could be expected from such a registry and would feel that the nursing profession had built in some safeguards which would be meaningful to them in their use of a registry. Just presented to you. This is your wish. I would work with it for a few definitions of my life.
Good evening, and I am very pleased I can be with you tonight. I hope I can be helpful. I'm going to back up just a little bit, if I may have the privilege, because I think to understand some of the remarks which I wish to share with you, and I hope that they will then encourage you to react to my comments as well as the proposal that is before you. My interest in private duty nursing began in 1940, and I was asked to serve on the registry committee of the Central Districts Registry in District 5 in Boston, Massachusetts. I found out very soon that I knew little about private duty nursing and registry management, and unfortunately I'm one of those who learned on the job. After I had served on this registry board for several years, I became convinced of the appropriateness of the role of the private practitioner in the delivery of health services. My interest has remained in this area over the years, even though my position And I think that the association has never fully explored the potential of private practice as a method of delivery of health services. Now, I believe sincerely that society, the community, the recipients of nursing care desire this method. They will have this method. They have every right to expect quality in this method of giving nursing care. And I'm talking about private duty nursing, private practice nursing, or in any type of a private contractual arrangement for delivery of nursing care. Now, if I can continue, and then I will speak specifically to a question that's been asked, is I need to talk for just a minute on the restructuring of the national level of the association, because I think it has a bearing on what is before you as practitioners in the field of nursing. The American Nurses Association's leaders over the past decade have been concerned that the arrangement nationally to deal with the concerns facing the profession, there's something wrong with it. A decision was made in June of 1966 to make a change because there had not been the visibility in the national arrangement, there had not been the visibility of the practice of nursing. And so we reconstituted an arrangement whereby divisions of practice could deal with the content of nursing practice. Any change offers a threat to some people. It is disturbing. It's disturbing to all of us. What appeared to be an elimination on the national level, in the opinion of many of us, was really an opening of a door, a big, wide door for the practice of nursing. And I can think of no group who has carried forward the practice of nursing over the years than the private practitioner of nursing, sometimes against almost insurmountable odds. There have been problems, as you can attest to. But since the formation of the Organized Nursing Association that was made in the late 1890s, the one identifiable group that started out were private duty nurses. Now, I believe sincerely that the community needs the services given by private practitioners. I believe the issue before us is the methodology by which this can be arranged. And that is the whole subject of a nurse's professional registry. Now, we have had a pattern of nurses' professional registries over the years in which it has been sponsored by a district nurses association. The fee-charged registrants was expected to underwrite the operational cost of nurses' professional registries. In many instances, it failed to do this. In other instances, bank accounts accumulated. Now, I think that your problem, a problem before you, is the cost of operation of a method of delivering a service, and it has absolutely nothing to do with whether there should or should not be private duty nurses. Whether there should or should not be this method of delivery, it is really the arrangement for it. And I'm talking primarily about the business operation of the management of a registry. And I think this is a problem that's faced by your total district association and the private practitioners specifically. Now, traditionally, the nurses' professional registry confined itself to the placement of started prior to 1920. It was envisioned that this was not to be purely a business placement or a commercial placement of people, but it was to involve a counseling and placement service, a professional adjunct of the district's programs and operation. Now, over the years and for many reasons, it was not possible to keep this ideal, and we've had many adjustments from the original intent of the district's involvement in assisting a segment of its members to receive professional counseling and placement service in their daily placement accepting calls. Now, we have a situation now across the country in which the approximately 155 nurses professional registries that exist this year, they're faced with many complex problems, money being one of them, competition from other types of placement services. Now, I think that if we assume that a small segment of the nurse population that chooses to use a private arrangement for the delivery of nursing service can underwrite the cost of a complex business arrangement, I just do not think it is possible to do so. And so there must be supporting funds from other groups. Now, you have had examples here in which there have been supporting funds from other groups to help underwrite the cost of the registry. Now, registries over the country that have been faced with the problem of finances have had to bring in other groups to help underwrite the cost of the arrangement for the delivery of this type of health services. And so practical nurses were added. And in some instances, the whole group of assistants to nurses categories, and we use this term to cover aides and other different titles of this nature that are used throughout the country. I think that one has to question very seriously, what are the purposes of a nurse's professional registry, and does it include the placement of other than professional nurses? Now, if we look at it purely as a service to members, one wonders whether it should extend beyond our membership. If we look at it as a service to the community and the community's needs in the broad aspect of health care, then this type of placement service or distribution center, which I think is a better term for it, would include any who are needed, from sitters up through professional nurses. If you do have this arrangement, then I think the question before you is this appropriate to be sponsored by a district association? The business of placing people in the health care field other than the members of the association. We made the exception with practical nurses because traditionally they are covered by the Nursing Practice Act. And so we could say within the broad umbrella of nursing. But we have to stretch our imaginations pretty far to say that sitters or supportive services to nursing are nursing. Now, the economics of this over the years has been that private practitioners have attempted to spread out work. And so they have built in certain controls in registry operations to be sure that there was work for all. And this in the 30s, I think our records document some of the efforts that we made along the lines. The labor market situation for nursing is quite different in 1968. You know that there are demands on us. We simply cannot fill these, regardless of how we utilize professional personnel. So that the situation is quite different today than it was 10 years years ago or 20 years ago. And I believe the question before the group is the arrangement that was effective 20 years and 10 years ago still the most effective arrangement in 1968? And remember that these questions in no way are addressed to whether there should or should not be a professional registry, whether there should or should not be private duty nursing. I think that the demand speaks for itself, the community's need for this service. But I think what is basic here is where best can this service be managed, by whom, and at what cost. And beyond just the dollars and cents, it is the human resource cost. Because a lot of time over the years has gone in to registry management problems. This has been a time-consuming factor for boards of directors of district associations, of state nurses associations, of the national, and certainly of the group vested with the management of the registry. Now, the American Nurses Association's Committee on Nurses Professional Registry, which I serve as staff within my present assignment, has seriously considered the role of nurses professional registries in 1968 and tried to project on for a few years in the future. This committee believes sincerely that some new innovation needs to be described and applied in the delivery of this service today, and even more so in the future. And this committee has a report which will be available at convention and then publicized right after. And that is, when district associations no longer can afford, from a money standpoint or a human resources standpoint, that registry should be phased out and that other arrangements in the community should be instituted so that the community is not deprived of this essential private practice service. And so the issue is not to do away with it, but to seek different arrangements. Perhaps it would be more profitable for those who are using the service, the recipients of it, as well as the givers of the service. Are there any reactions to anything I've said so far?
Speaking of the phasing out, what is that anticipated?
The phasing out of a nurses professional registry should only be instituted after a very careful examination of what the situation is, and the decision should be made by those people most directly concerned. That would be the users of the service, private practitioners of nursing, the givers of the service, rather, the private practitioners of nursing, the utilizers of it, that would be the healthcare facilities, the hospitals, the nursing homes, patients in homes, and so forth. So that this is a decision which is arrived at after a very careful analysis of the situation. And if it is decided that this must be done, then I think there must be considerable discussion on how it is done, and then who picks up this service if it's phased out as a district operation. Well, we believe sincerely that the group that has really most at stake is the community. Because we do not give the service in the vacuum. There are recipients of the service, and I use the community to mean the patients, the patients' families, the healthcare facilities in the community. Now, I believe, regardless of whether a district association is in the business of helping to operate a nurses professional registry, that the community will come up with some method of doing it, because this is needed. It's an essential service. And there are situations throughout the country in which the community has arranged a service which really is called a distribution center because it involves much more than nursing service. And private practice nurses have used this distribution service and have been very pleased with it.
Is that a community fund or is it what they call a commercial?
Community, it's not a commercial registry as we usually use the term. And I think a part of the proposal that has been described today picks up in essence what the National Committee had worked through and had no idea, of course, this was being prepared. It's just a coincidence that they reflect basically the same thinking in relation to the problems involved in registry management in 1968.
And I told many this time in St. Louis, I think we allowed to get ourselves lost in a maze of making things new. You know, it's true that change is necessary, but it's also true that change is often experimental when it doesn't work. And it seems to me we've been going through a lot of changes in our profession and also in the world lately in the last several decades and half work. And we get this little mess and huge word every day. And we come back to a situation and say, oh Lord, we changing. It might be good to change back a little bit to where it works. Now we must forget that all these losing ourselves and all this victory, we get carried away from the basic things. We must forget that we are dealing with people's lives here. Now, when you bring these 30 papers to levels of nursing in, now you still won't have enough work for people to leave. Or you don't have your educated 3-year nurse or your 5-year nurse sitting up on the pedestal making the day down, while the other nurses are making most of the work. Now, see, that's not going to work, and wind up you're going to have less and less students coming in. It may be that education and administration are taking a little bit too much of the management of theirs. Maybe we should have some of the nursing in the nursing team, some of the consideration of nursing problems in the nursing team. Now, you break the situation down to this problem, a proposition. You're going to bring in an expensive person who's going to sit up and be a sort of dictator and tell us who knows nurse, judge us all, and tell us who can have this level of work and that level of work. The situation is that most of your nurses don't have to go somewhere and get something you make it. But personally, I think most bus nurses like our registries that we have. Our registries we have in the registry. And I think the problem has been why some of the hospitals put it out. Well, now, you say we need somewhere in public, yes, or why don't we do like the doctors, why don't we take a section in the yellow page for REs? And then let the hospitals do the screening of what REs they won't have in their hospital. Wouldn't that do away with a lot of expensive administrators sitting up on the board deciding who to do? The doctors have found that to work. I'm sure that we could manage to scrape up the money to pay for our place in the yellow pages. I would suggest that for my fellow private duty nurse. Let the company talk to the nurse. Now, we find a case where doctors order nurses around the clock in the hospital put on practical nurse. The hospital decides they don't need a regular nurse. All right, here's the new education department. Why do you educate these nurses? So it looks like you slipped up. They didn't need their education. I would say this, and I think that most governments have prove now that our hospitals are filled with nurses maybe instead of taking us all up playing with us and deciding who can do this, who can do that, we'd be crooked like we are. We've learned how to play, and I expect that some of us could tell y'all something in the city. I love you, try. You know, you do pick up a lot of tricks when you're on here. You pick up a lot of little knowledge, little hints and things that are clear to you to understand what's going on in the cities. And you're not going to learn it by taking the course and taking blood pressure the city needs. You simply are not. What do you think?
Thank you, Mr. President. Mr. Hudson, what do you know about the United States Department of Labor employment services that function as registries for nurses? That's been used in some places.
Yes, it has. The state of Pennsylvania has used it rather extensively, and I think quite successfully. Here again, the move into using the United States Employment Services regional offices was precipitated because of the cost of operating the registry within the association. It was not by design, other than they were forced to do this. The arrangement with the Employment Service has been that they manage a call system for the placement of private practice nurses. In most instances, there has been a nurse employed who has manned an office between 9 to 5, and an answering service is handled between 5 and 9 the next morning. Now, if any of you have operated with an answering service in connection with the placement of professional practitioners, there is much to be desired. The standards, it's almost impossible to maintain standards under this arrangement. There's no question but what an operator can efficiently communicate certain information, but a great deal more than this is needed. Now, that has been one of the disadvantages. The advantage was that there could be an arrangement at basically the taxpayer's expenses rather than a small group or a part of the association underwrite the cost of this placement service. Now, some associations, district associations, have refused to use this service, and so they have let the registry just disappear. And so a community has been without any type of arrangement to assist in the meeting the community's needs for private practice nurses.
For many years, the Fifth District Nurses Association, private USAC, has fully maintained the registry in our district. The private nurses paying a certain amount of money to keep the registry manned around the clock. And for many years, all hospitals used this registry, which meant if you do private practice, you had to belong to ANA hospital registered nurse will go back and use our registry and let us take any kind of examination anymore, and let us participate, which they have already to do in certain programs. I know we have a lot of good private nurses who happen to like bedside nursing. They can do anything else, but it's the only kind of nursing left that is really bedside nursing. Let's face it, you have ICU units, you have intensive care, but there will never be anyone that takes the place of that nurse in that room where that patient can sit. If you sit there for a minute, to know she's there, you turn that light on, you need an ICU, they may not let you in. Because I've been in all these departments too. And we have older nurses doing private duty nursing, and maybe this nursing, and maybe they're not capable of doing what some of us would do, open hard and sheds, which take a little bit. But they do have a place, and they have worked long and hard, and they do get to earn a living, or they wouldn't be on the register. So I think the levels of nursing, that the government set it up, the hospital would come back to the central registry, and everybody in the district should pay a certain amount if they are a nurse. Keep our registry open, just like the pay dues to the district, and the state, the AMA. Why not let them have support our registry? After all, they're benefit from to this community service. And what is nurses who do general duty don't even belong to the state organization, the AMA. And we have to belong to it. We've always had to belong to it. So now let's set up our levels of nursing. Let's grade our nurses any way that's practical. I'm sure the older nurses who are not capable of doing venous pressure and all the things we have to do with chest cases, they can't do that, so they try to evaluate themselves. Maybe they can satisfy them at $5 less, $2 less, $3 less. But there are some other young nurses who really like bedside nursing. It is the only type of nurse I feel I can do a good job.
I would like to speak to Ms. Longford saying that only private duty nurses are required to join the association. And just indicate that I had mine when I came to St. Joseph's as director, that I would do as I had done in Michigan, require that everybody who was employed in our institution would belong to the GSNA. I found out I couldn't do that.
That's right.
I found out I couldn't do that. So that's the only reason. Now, you have, Mr. Conlon, made the statement that if these other people are involved, what will happen to us? Well, I just sent down personnel Friday, I believe, a request for recruitment of at least 20 staff nurses, 11 or 12 LPNs, and 18 nursing assistants. There's plenty of work for everybody to do. And it doesn't always, not every patient requires the use of a professional nurse. But what we encountered at St. Joseph's, and you know that we use the registry all the time, is that the registry is not always able to fill all our calls. Now, somebody, I think Ms. Conlon again made the statement that the hospital will decide that LPNs will be put on the then they may be put on, because this will be better, we hope, than not having anyone with that patient. One other remark, and I'll stop. A comment was made about sitters being picked up off the street and put in to stay with patients. And again, I'm speaking only for our own institution. We have been working with the Georgia Department of Labor, who, in cooperation with the American Red Cross, the Senior Citizens of Atlanta, and one other organization, I'm not sure whether it's the Georgia Hospital Association or not. But anyway, they recruit, the Georgia Department of Labor recruits people from the older age group who can be trained to do certain things for patients. These people are trained by the Red Cross, Mrs. Bell, the Red Cross. And then they get better treatment than you do right now, and I'm ashamed to say this, when you come to our institution. Today, for example, a group of them were brought to our hospital, were interviewed by the associate director, and a certain screening process was done, and it was decided who would be kept. And then they were put through an orientation. And you don't get that when you come to St. Joseph. I'm sorry to say you don't. I hope I live long enough to see and can see the time when you get better service than you do. But it's not, I can't say that there's not, it isn't true that people aren't picked up off the streets and put with people to take care of them. This may be so, but I do know that this is one program in which we are cooperating, and we have been forced to do this because we need people really to sit with people and keep them from falling out of bed. We have more and more older people, as you know, in the hospital, and we can't always get private duty nurses of either the registered professional nurse or the LPN category.
May I make one suggestion? In New York State, if you are not a member of the register, professional nurses register, and you ask for duty in a hospital or in a nursing home, and you are not a member, you have to pay a certain percentage of your daily salary to the register. If that were practiced in Atlanta,
bought a home here in Marietta within 9 miles of Huntsville. I went through the process, or started through the process of moving my membership to 13th District. I was welcomed, everybody was very nice to me until I started to join the registry. I'm a member of the ANA, the GSNA, the 5th District, and the Nurses Professional Registry, and have been for 20 years. I've worked regularly, I presume, I don't know, but I presume that my references would be within order. But the registry in the 13th District is closed to new members. Yet, within my own neighborhood, within 2 blocks, people are applying for private duty nursing. They tell them that they are not available, but I'm over there on Octavia Line. I have to drive 33 miles back to Atlanta to work. Now that is one of our problems of distribution of private duty nursing. Don't misunderstand me, I'm glad to come back to him. But it would be a lot more convenient for me to nurse in Marietta and the few patients I don't know the courage, but they have been in dire need of private duty nursing. What I want to ask Mr. Hudson, can a registry legally close its doors to new members if they are qualified?
The answer is yes, because the rules of operation are made by the committee or the board of management of the registry, which in 9 times out of 10 is composed of private duty nurses. And so here I would assume in the situation that you described that it is your own fellow practitioners who have set up an arrangement to protect their own work.
Well, is the ANA approved this?
The approval for nurses' professional registries is done by each state nurses association. National only suggests guidelines for the operation of the registry.
Well, I'm not complaining for lack of work, but as I said, it would be more convenient. Mr. Hudson, actually, 13th District does not have a professional registry. This is a registry operated by the, well, I talked to the private duty chairman 3 times, and she told me that they were closed, as all Indians do. However, this is not a professional registry. However, she did say my name, and she told me I would be the only one with it. But I don't see how they could accept me as a member of the 13th District. I mean, it's not giving an opportunity. We need to distinguish between a professional registry and a privately operated registry. And 13th District is not operating this registry. It's a hospital operating. It is furnishing professional services, let's put it that way.
Well, that would be true of any commercial registry that places registered nurses. I think that the point that's been raised is the policies that govern the management of the registry. ANA, through its national committee and for years of discussion with groups of private duty nurses, have attempted to outline guidelines so that there is a fair management of this service. Now, the district association has the responsibility of the management of a nurses' professional registry, which has been approved by standards established by the State Nurses Association. All of my remarks are related to this type of an arrangement and would not apply to any way to deal with the problem is to examine it carefully and suggest methods of solving it. Now, you cannot solve it alone because you are not alone in this total picture of service. The healthcare institutions or agencies, and I use that simply because there are more than hospitals involved, they have a voice in it. The patient has a voice in it. The professional organization, the District Nurses Association, has a voice, and you do. And since there are these groups involved, no one person can, or one group, make the decision. Now, you could say that you will all pull out and set up a registry to your liking. You will manage it. You will underwrite all the expenses of it. All right, now who's going to use it?
We have underwritten all the expenses of it all these years.
But the hospital schools
Why do they pull out?
we don't know.
We don't, because we're not $25, we have a lot of equipment.
It's already that much a group of practice themselves. They went out.
When you
They
live,
want to split up the group and divide up.
when you listen to me for a minute, since I'm the only, I guess, I'm the only nursing service director here, if you would, it was my understanding, from what I have heard about the history of the withdrawal of some of the hospitals, that it was not simply a matter of money, although maybe we would have to concede that this might have posed a little bit of a threat in that salaries in some of our hospitals have been very low. Now, this is no longer going to be so because the salaries are coming up very rapidly. With that in mind, the other reasons, the more important ones, it seems to me, if they were true, and I have no more reason to doubt the directors than I have to doubt you. I don't doubt either one of them. I have no axe to grind it anyway. That they were not able to meet the needs through the private duty registry as it was set up. And only, and I'm thinking now of two nursing service directors that I talked with in detail about this, because it looks like St. Joseph's going to have to do the same thing if you close the registry. These two directors said that as the registry was being operated, they were not able to meet the needs around the clock, for one thing. And neither were they always able to fulfill the patient's needs from the standpoint of competencies. But now, I'm talking now about two nursing directors in particular, only. They say that over a period of time now, since they have operated their own, they have been able to do something in the area of deciding about competencies, and they have set up regulations which have assured, if you were talking, I would not like with you. They have also been able to see nurses, or they'll continue to have their own. It's that simple.
In a way, I don't know, but, I wonder if the hospitals have used their own registry, still they have gotten better service and better nursing care. Is this true?
From the nurses,
Yes.
from the nurses that they have included.
They are able to screen with that.
Yes.
They feel they
This
get
is
a better
true.
patient care.
This is true.
Well, this is what.
I mean, this is what they report.
And that's why I wonder, when we set up our own registry, of course, everybody belongs to the registry, and they try to screen them, and what I still think that they need to do is get better information from the hospital, so that the nurse, the registry could screen the nurses, and then they in turn tell nurses service. The nurses service must know these nurses, and they can reject them if they say, someone knows coming over with medicine scale. And nursing service doesn't think this nurse is capable of nursing this case, and they can refuse, which is what we're doing.
Well,
It didn't work.
for one thing, in relation to having this central distribution agency, I like that term. It would be much less costly to all the hospitals, for one thing, because now it takes a full-time person in the hospital to have their own registry. And of course, we at our hospital, it takes a full-time person there, really, to use the registry. But we feel that a lot of the work that needs to be done could be done through such a plan as this. Maybe this plan couldn't be accepted, but if you have asked us for suggestions, we have given them to you with the hope that they would be of some help.
What I'm just to say, the private nursing section did send this letter to the director of nursing, asking for their suggestions, and this is what they sent back. And in the letter, the director promised to give their support to this vibration and to cooperate with all the development of programs to ensure necessary safeguards to participation. And now, if we want them to come back from it, this is the time register they will come back to. But if we want them to keep their hospital registers, then they'll keep, rather than go back to it. So they can make an answer from us.
She said the majority of nursing directors would go along with this, because, the directors work on the program, we work on one, get together, and then a couple of hospitals say, well, I'm sorry, I'm not gonna use the list. Then what about the nurses that go to St. Joe's and you're not using them? Right.
I'm not sure I follow you. Would you say that over just like you said it before?
Well, you said the majority of the directors were in favor of this.
What I meant to say was that the majority of the directors were present at this meeting and approved it.
Well, what I would say, if we do all this work and work up recommendations to the directors and vice versa, then we get together and a couple of the hospitals don't want to use it, then what about these private units? We're still right at the start.
It might be, it may very well be, that there will be some hospitals, and I can think of one or two, who would never give up their own registration.
That's what So, I'm Helen Moore. I have a letter here in my heart. It's the medical director of Carolina Hospital stating, this is June 7, 1966, that due to the $25 increase of the graduate nurses, they were forming their own registry. And that is one reason that they pulled away from the
the word for the central registry for this. I know they have done a good job and did do a good job because you and I and everybody knows there has never been enough to go around.
That's right.
And the central registry certainly tried to distribute their nurses fair and equal. No hospital ever got every call filled like they wanted to. And we know for a fact that a lot of these hospital registries are using their own personnel when they have their days off. They come down and say they want it. That's one reason why they're getting more filled. They're also doing the staff nursing for the hospitals on their days off and coming well and good if they can get their patients covered that need it. But it isn't right to let nurses sit waiting for calls when they know they want it. I believe there are girls right here in this audience now that get up and say so, that have called in, wanted to work over the weekends, and were told there was nothing for them. The next week they went on duty, found families that they had nursed for before, who had been pleading for a week for nurses, and they were told they didn't have anybody available.
That's
And that's happened, some of this audience tonight has happened to, and I wish they would get up and say it has happened to me.
And we didn't have to make, she not
I'm just reading this from Mr. Hudson's benefit. It's just something that I've jotted down before I can let it go about the increase in fee and the objection that we had from the board and most of the directors of nurses that were on the board. August 1963, Mrs. Ann Stevens was elected chairman of the County Section DSNA for 5th District DSNA. December, and one of our other members has already spoken to this raise and fee. December 5th, 1963, our raise and fee was voted from $18 to $20, effective date March the 1st, 1964. I, in reserves, became chairman of the private duty section in 1964 because the chairman resigned and I had to step up, and served through August 1967. Another raise in fee was voted effective date June the 10th, 1965, from $20 to $25 for an 8-hour shift. Now that's just a parenthesis to tell you how I came to it. And from then on, in the fall of 1963, the private duty section raised their fees, as I've told you. This was not well received by the directors of nursing. In fact, the second one was proposed in June 1965. They opposed it and even started setting up registries. And the articles that came out in the paper even stated that they were doing it to combat the rates of fees. However, we contacted AMA at the time, and they commended us for it because we had just come back from the Atlantic City, and it still did not come up to what the beginning fee was that they recommended. And in June of 1964, at the January 1964 meeting, changes in the bylaws which proposed to establish an advisory committee to the registry committee, proposed most of the nurses and directors and one doctor and one private duty nurse, was opposed by the private duty nurses, and they had their reasons, and because they had already opposed the raise. And this proposal was voted down in the January meeting, and without proper notice, the same proposal proposed changes in the bylaws were presented again at the March meeting. The changes in the bylaws were voted upon and passed. The parliamentarian of GSNA declared the action taken in the March meeting on the bylaws to be null and void. The present parliamentarian that we have now agreed then with the past parliamentarian and has stated in writing, March 10, 1967. In my opinion, the procedure was not correct, yet to my knowledge, the bylaws now in use have never been legally adopted. A few nurses say forgive and forget, but many nurses, possibly near 100, have failed to join the district and registry since the bylaws were illegally adopted. I think that has a lot to do with some nurses dropping off. But I do want you to know that we did have much opposition against our raise in fees. We also invited the nurses and the director at that time to come and meet with us in this very auditorium. And I think only 2 hospitals had representatives. We also invited the directors of hospitals themselves, and we had 2 hospital directors to come. And there were a lot of talking going on, and a lot of, as I say, just we reverberated and talking about difficulties we were having. We came to no solution. The nursing directors did not cooperate. They did not accept our invitation when we extended it. We have gone poles apart, and we must come back together in some way. But we feel like that an organization, I personally feel that an organization that has not adopted their bylaws properly and legally, I'm wondering, what raise the question, have the right to operate? Now, this is one thing that has made such a division. And some of the nursing directors did pull out and form their own directors just to try to defeat our increase in salaries.
You see, actually, you're in the rough and tumble game of business mixed up right in the middle of your professional association. And you haven't seen anything yet until you have seen an economic security program in action. And then is when you're going to see pressures, power groups. Now, this is one of the reasons why I bring to your attention, because I'm trying to serve as a consultant with certain information that may or may not be helpful specifically to what your problem is. And I have to fumble because I'm not really sure what your problem is. But I've heard from many of you, and I am hearing things that aren't even being said. My concern is the purposes of a district nurses association. And the question of a district nurses association in the business of a commercial placement service. And I'm using commercial now differently than I would if I were talking about a registry which is not a nurse's professional. Let me rephrase that again so I'm not more confusing. Is that when money is exchanged for this type of service. Now, if you had an arrangement outside of your district nurses association, I'm not saying whether you should or should not, I'm only raising the question, if you did have one, and if you shared in the management of this, then the normal problems of management would not then be a part of your relationship to your professional association and I have watched tragic situations over the country where private duty nurses have pulled out of the district in protest over the management of a business arrangement or the way they get work, and have then penalized the professional associations I think they really believe in and want to support. And all I'm saying is that you need to look very carefully. Do you have the best arrangement? Have you thought through the best arrangement for meeting your needs, or having a professional association and having the community needs met? And you people have an important voice in this, but you don't have the only voice.
Mr. Hudson,
Yes.
one of the hospitals that formed their own registry, the director of nurses told the nurses that joined our registry that we did not have to be members of our professional organization in order to work for the hospital. I did want you to know that.
Yes.
That included A&A.
Now, I have a feeling that this won't be a very popular remark I'm going to make, but I feel as a professional person I should make it. I do not believe it is the responsibility of an employing agency to see that a professional person is a member of their association. That is the professional person's own responsibility.
I feel that way too.
I disagree with you, Mr. Hudson.
I'm sure there are many who will disagree with
But
me.
they
I'm not-
hospital, and they are responsible legally for the actions or whatever they have to do that nurses train, they lack training. I think they're very stupid if they don't insist that they belong to a proper professional organization. My opinion was stupid.
I believe sincerely that the professional association stands for standards. And that's why most of us are a member of it. It should also stand for one of its main purposes, and that is educational purpose for the improvement of the practice of nursing. And we should have every right to expect this from our association. We have expectations as members from the professional association.
I feel this poses a great threat to the whole national organization, simply because of one of the things in which risk, the treatment has been, forward, that, the city district's private university section got, it's done away with, and when that attitude, I know I wouldn't carry it along. And already, it's private section that supports the, section of, part,
Well, I think every nurse has to answer to herself the reason why she would belong to a professional association. If it is only as a means of getting work, then you've answered your own question. If it is because the association stands for something beyond our immediate work situation, then you have another answer to the situation. Each one of us must resolve this in our own way.
Have you read this, are you familiar with this,
Yes, I am.
well, you stated a little earlier that the structure will change, the registry is active and convention. Then are we wise in, studying and considering this, or waiting until after your new structure has come out with a fine, have to come to?
Would you want me to read, and there are, I think, just 3 very short paragraphs from the report that will be presented to the House of Delegates that reflects the thinking of the National Committee on Nurses Professional Registries? All right. Now, remember carefully what has been presented to you from another group who looked at an alternative method. And this is what the National Committee, made up of private duty nurses and registrars. And this report will be available to all the state and district associations immediately following the convention. And I'm reading from registry services. Such registry should be phased out from ownership and management by the District Nurses Association. Phasing out of a nurse's professional registry should be undertaken only after careful study and consultation with registrants who are providing private nursing care services and with directors of nursing of healthcare facilities who utilize these services. When a nurse's professional registry is phased out, the District Nurses Association, in fulfilling its professional responsibilities, should exert leadership in cooperation with private practice practitioners, nursing services of healthcare facilities, other community health agencies, to enlist the community's initiative in developing a nursing and auxiliary health workers recruitment and distribution center to meet the community needs for private practice nursing and other nursing services. Now, this parallels very closely a proposition which was suggested to you as a method of dealing with the problem, because I believe that you cannot continue an operation that does not have financial resources to underwrite it. And if you say, if all these people return, if all these other factors are met, but how do you get the show on the road for these people to see what's going on to return? And I think that you're faced with this very practical problem. Regardless of how much each one of you might want, anyone else might want, the registry to continue just as you have known it. How are we going to do it?
It's for all the hospitals to reciprocate with the registry.
Well, I would assume that this is one way to solve the problem, and I think you got an initial approach. And I don't think the directors of nursing meant this to be the final word with every I dotted and T crossed. This is an initial proposal. And I would assume that you people assembling a smaller group so you can talk about this and so forth, would look this over carefully and see what are the merits to this. Because you have to get off dead center somehow.
Well, Mr. President, I would think we shouldn't have our credit registry. We better let hospitals have their registry and let the nurses belong to all the registries. That is, go around and make contact with all the different hospital registries and be on all the registries. That would affect the same thing, and it would be a direct confrontation with the hospital with the nurse. And so said the hospital was bad expense in
I think maybe we should talk a little bit about levels of practice. You want to? All right. As I said before, the groups, I become very nervous when I talk about levels of competency. We have not done a very good job in nursing in defining what is basic nursing. We're still fumbling and trying to define basic nursing. And until you make that definition, how do you know whether you're above or below it? Now, levels, when we use the term levels, to many people that infers good and bad. You're better than, you're below than. And this is a dangerous thing to be doing because most of us are not intimate enough with the situation or an individual practitioner's competency to make these judgments. This is a serious business. Now, who do you give the authority to make these judgments is part of the question. Now, are you going to turn around and look at each other and say, I judge you good, I judge you secondary level, and so forth? Now, this can be done. Practitioners can judge each other, but sometimes it becomes just a popularity contest. Now, are you going to have the nursing services, the organized nursing services, judge you, and on what basis will they make their judgments? Are you going to have doctors judge you as to levels of competency? Are they in a position to judge your ability as a nurse? Our whole profession is standing on the point that the judgment on nursing is made by nurses. We do not ask the medical profession to make a judgment on quality of nursing. Their business is the practice of medicine. Now, they have an influence, a very definite one, since they are responsible for the overall medical plan under which nursing is carried out. But I think that there is a distinction between the practice of medicine and the practice of nursing.
I think the doctor who, suppose I'm on the patient Dr. A, well, he is more in a position to know my level of nursing. He'll know in the first 10 minutes whether I'm competent or not. And he'll know by the time the person is ready to go out whether I would work of being a professional, as a professional nurse. I think if anyone does to me, I would prefer to be a doctor. But I agree, I'm very closely associated with him. They can question me on any subject. If I can't answer that subject, then that's what my competence is. And I think, I don't think another nurse should be one who judges me or a director of nursing. Because many directors of nursing haven't had the experiences that I have had. And I'm not saying personally, I'm talking about we're all individuals. And I think some directors of nursing, some of them, I haven't had directors of nursing who have asked me.
I respect your opinion.
Now, I have never met a doctor that I could ask me a question, or that I could ask a question.
You see, I think we have to separate out now whether we're talking about the scientific knowledge that, no, I'm talking about the practice of nursing, which is based on scientific knowledge. And I think what I'm talking about is the judgment that a nurse brings that distinguishes her practice from a practical nurse.
And the person who's less educated as the doctor, I'm not a private duty nurse. Private duty. We're intimately associated with the doctor and the patient. And they are the two who can judge, as we know in Western world.
Well, the American Medical Association has been quite vocal, is that they do not feel they are competent to make judgments on quality nursing care. Now, there are individuals that depart from this, but we've had many serious conversations with our partners in this operation, doctors, and they are the first ones to admit their Yes, I suggested that legal counsel should check out any arrangement which involved the placement of non-licensed personnel as an activity of the district, because the tax exemption status for your association can be taken away on this very issue. Now, legal counsel would make the determination I would be appropriate to do this, but I understand that your registry is not incorporated, your district is not incorporated, but your state association is, so you could really jeopardize the whole arrangement for your entire state association by some type of an arrangement of placement of non-licensed personnel, which you would be totally responsible, you being the registry management, for the placing of these people and what they did or did not do. Now, you may be fairly free of lawsuits in the state of Georgia. I just returned from the state of California where they sue people, just at the drop of a hat. And they are overly conscious about this problem. Now, it may reach you, it may never reach you here. It is something which I think as professional people you should be sure is checked out before you assume this type of responsibility. Because remember, the purposes of the association, bylaws set up the purposes of why you have an association, I don't think can be stretched to the placement of non-licensed, non-member personnel. Now, we've done it with practical nurses, but they are licensed in most places. And it's part of the consideration of this whole package that you need to look at.
Would you go back to the discussion of the levels of nursing that you did this afternoon with us?
I'll try. I think I got it too. I'm sorry.
What's happening in California?
Yes. The National Private Duty Section, and I worked very closely with that section over the years, issued a document in which they spoke about classifications of private practice. And this document was based on an experiment that was tried in California with their private duty nurse section. And they had an arrangement whereby a committee of private duty nurses passed on the competency of their fellow private duty nurses. They made determinations that by attending a certain number of in-service programs, lectures, formal or informal courses, that one built credits towards this classification. In other words, this type of exposure to information helped you become a better nurse, practicing nursing. Experience also were part of the credits towards this. Those nurses who met the qualifications set up by the private duty section in this particular district then became classified and charged a different amount of money because they had documented their abilities to perform a different level of nursing care, and they were specific to cardiac surgery cases and certain other situations. Now, when I was in California last week, I inquired on how successful this operation is. And I was told that it is very difficult for the group really to determine the competency of itself. And that the public or the hospitals and so forth have really not been utilizing this arrangement. Now, on paper, it looks wonderful. In operation, it's a different matter. Now, I think the intent to improve practice, none of us argue against this. From this paper, which you have the number of copies that you want of it, I think that you can build a system which will help in the improvement of your practice. I'm sure every one of you want this. But I go back again, is that moving without careful thinking into describing levels of practice may work against you as well as helping you. So I look at this very, very carefully.
something happens here, it's gonna be better, so they have somebody else. And how can, we be expected to know all types of nursing when the doctors can't know that, all that, the part of medicine?
Well, I think that's one of the points, is that you choose an area of practice and you attempt to become skillful in it, and new information is being fed in all the time. Now, you cannot cover the waterfront in nursing. There were decades ago you could do this, but you cannot do it today.
Well, I think another thing too, is this, extra study degree, and yes, I don't think the evening nurses are considered very much. Now, they provide, usually whatever's done is done, after the day, shift. And the day nurses and the night nurses, they get that pretty easy. But the evening nurses are left out when it comes to education.
That's right, and I think that more and more groups are looking that they must hold programs when people can attend. And this creates a problem, but it is not an insurmountable problem. And there are places in the country where programs are held so that people on the various tours of duty can attend.
Mr. Hudson, why is it that the great problem is needing more education for the RN, and she's not confident that the same position can be filled with a practical nurse without any trouble? Is that what we are getting now? The RN is not being satisfactory, but the hospital can call in the practical nurses, they're more confident, more educated. It seems like that our educational system has slipped up from that, and we over-educated nurses to their detriment. And now we're finding that the less educated nurses will come.
You said that, Mrs. Conley, we did.
Now,
taking advantage of the programs is one specific step. I think that you will have, as a group, to come to a decision as to whether the financial arrangement of the Nurses Professional Registry is possible. A financial arrangement is possible. Now, this is a pure business decision. Now, I think that as a group of practitioners, that there is no question but what some arrangement will be made so that you can deliver your nursing services. And I go back that other groups are involved, and I think that all of you together are moving towards some type of decision. And it's obvious that it isn't here today. But I think that you are making the right moves towards this. And there's going to be some negotiation compromises. It would be entirely different if there was a question, are you needed? You see, this would be an entirely different factor. There is no question of that whatsoever. So I think that the fact that you can come together and talk tonight, that you have proposals that are being fed into you, and I would hope that you would make some type of proposal as you see an arrangement. And this you have to do by getting together and talking it over and submitting a proposal. And by negotiating back and forth, that you will have an arrangement, not satisfactory to all, but to the majority.
But in the end, the patient is the one that decides.
In the end, the patient will get better care if you can make these decisions.
Yes, but right now,
I would like to say two more things. Ms. Ditcher is sitting right there, and I promised her I'd bring this up. First of all, I want to say this, that if you are interested in working further with the nursing service directors, we will be willing to work with representatives of your group, and we will invite representatives of your group to come to our next quarterly meeting, if this would be appropriate. This was discussed at our meeting last Thursday, I believe it was. Now, I want to just mention this because Ms. Ditchfield has been asked to come to a meeting, be a participant, represent the Association of the in relation to financing something. You know, we have a regional medical program now, through which a number of programs and projects have already been started. At St. Joseph's, for example, we have secured financial